Hi, I'm Dr. Jay Varma, and today we're going to be discussing how you detect and respond to infectious disease outbreaks. Whether you come from a health background, a policy background, or you're just a curious person, we're living in an age where infectious diseases are rising. There are threats both domestically and globally. And so it's important to understand how public health agencies actually detect and respond to these increases in infectious diseases. Today, we're going to be covering the following topics. How do you monitor infectious diseases in a population? How do you decide that the number of people with an infectious disease is something to worry about? How do you investigate the cause of an increase in people with an infectious disease? And how do you select policies or programs to reduce the number of people with that disease? So, first, we have to understand the foundation of public health is something known as surveillance. What is public health surveillance? There's a long definition that's been used by CDC and public health experts for a long time. And that definition is it's the ongoing systematic collection, analysis, and interpretation of health data essential to the planning, implementation, and evaluation of public health practice, and closely integrated with the timely dissemination of that information to those who need to know. Public health surveillance provides information for descriptive epidemiology. And by that, we mean describing the person, place, and time of people who have a certain disease. It also provides information for public health personnel, government leaders, and for public policy and programs. Who is responsible for public health surveillance? In the United States, public health surveillance is fundamentally a government activity, and it occurs at the national, the state, and the city or local level. And each level of government has a public health agency. If you think about it, where I live in New York, at the national level, we have CDC. At the state level, we have the New York State Department of Health. And at the local level, we have the New York City Department of Health and Mental Hygiene. Each state in the United States has responsibility for collecting data about people with special conditions. We define each person with a disease as a case. I'm going to continue to use New York as an example. In New York, for example, there are a list of 80 diseases. There is a requirement for healthcare providers to call, fax, or enter information about cases of these diseases in an online system. There's a requirement for laboratories to report any persons who are diagnosed with these diseases using what's known as an electronic clinical laboratory reporting system. And for infectious diseases, the gold standard is really this reporting done by laboratories through electronic systems. It's challenging, however, because this needs to be done in a way that ensures that all labs are actually complying with this reporting requirement. Why do public health programs want you to report cases? Well, first, they want you to monitor cases of disease over time. Second, they want to help you detect outbreaks. Third, they want to evaluate prevention and control programs. And fourth, they want to identify close contacts who may require testing, treatment, vaccinations, and possibly supportive separation, known as quarantine or isolation. And this is most important for diseases like HIV, syphilis, tuberculosis, and during the recent pandemic, COVID-19. This is a slide showing you the list of reportable conditions here in New York City. And these, as you can see, there's a huge list of these diseases. And they're broken down into a few broad categories. Those for which reporting is meant to be done immediately. And immediately essentially means you must call anytime you suspect somebody has this condition. And those are because these are conditions for which there's an incredible and urgent need to intervene. They could indicate bioterrorism. There could be a large public health outbreak associated with them. And then there are other conditions that are argued or that are defined as only being reported within 24 hours. And those are conditions for which, again, there's an important public health reason to be reporting them, but it's not quite as urgent that they get reported to public health agencies. This shows you a slide of how you can track public health surveillance. For the next several slides, I'm going to be using COVID-19. So this is an example that most everybody in the world is aware of, and it's kind of easy to use data from this period. So we're going to look back at some periods during the peak pandemic. And here you see a slide from the New York City Health Department. On the bottom axis, you see time. You're looking at from April 2020 through October of 2021. And on the y-axis, you're seeing the number of cases that were counted through these public health surveillance systems. Now, public health surveillance isn't just about humans who have a disease. It's also about what happens to humans when they die. In public health, one could argue that the single most important piece of data that any public health agency collect is data about who's dying and why. So that's why they're considered vital statistics. So just like we talk about vital signs in a healthcare facility, like the heart rate and the blood pressure, we also in public health talk about vital statistics because they are so important. Vital, in fact. Every person that dies has a death certificate that is signed by a doctor. This is known as reporting the fact of death, the occurrence of death. The doctor must also list the causes of death on a death certificate. In New York City, that system is now entirely online, but many jurisdictions still complete that via paper. Note that in most countries around the world, they actually have highly incomplete recording of both the fact of death and the cause of death. This shows you an example of what the paperwork would look like if you were filling it out manually in New York City. And it shows you that there is a challenge in trying to figure out what the cause of death is. This fundamentally relies on a physician's judgment about what happened. And the causes of death are broken down into intermediate or underlying causes, as well as the immediate cause of death. And it's important here to understand, too often there are physicians or healthcare providers that'll put something like the patient died of cardiopulmonary arrest. That means their heart and lungs stopped. Well, that is actually the method or mechanism by which everybody essentially dies. The reason you die is because your heart and lungs aren't working anymore. And then eventually no blood and oxygen gets to your brain. Can't think, you can't function. So that's not what public health is interested in tracking, because obviously 100% of deaths would in some way be due to the heart and lungs stopping working. Instead, public health wants to know, were there factors that put you at very severe risk of dying and are causally related to your and death? And then what was your immediate cause itself of death? So here we have with COVID-19, again, how I showed you before, tracking cases of death, we have deaths caused by COVID-19. And this is, of course, as almost anybody knows, a hot area of debate, even to this day, because we know that COVID-19 might be the reason somebody gets hospitalized and ultimately the reason that a person may die, but it may also be a factor in their death for other reasons. We know that COVID, for example, can increase the risk of heart attacks. It can increase the risk of clots. And so COVID-19 may be a contributor to death, or it may be the actual cause of death. There's also a debate about whether people might die with COVID. So, for example, they come to the hospital with a car accident, and when they get tested, they actually have COVID. That turns out to be an extremely small percentage of the cases. And we suspect that means anybody who has studied public health death statistics related to COVID, that throughout the pandemic, the cause of death was actually of being related to COVID was actually undercounted rather than overcounted. And that's because COVID can cause so many other complications beyond simply having respiratory illness that we all classically think of as what happens when you get that infection. Public health also does surveillance for what we call clinical syndromes. This is also known as syndromic surveillance. So in this situation, you're looking at when a patient comes to a healthcare facility, are they complaining of symptoms or do they have signs on their physical exam that could be a disease? So in other words, we haven't actually diagnosed them, for example, with pneumonia, but they are coming in with a fever and a cough. One of the most common clinical syndromes that we track is what's known as influenza-like illness. This is defined as either somebody presenting to a healthcare facility with fever and a sore throat, or presenting to a healthcare facility with fever and a cough. So now I'll show you data again from the New York City Health Department showing you how the health department tracks influenza like illness. The reason this is important is because we know that many people with respiratory symptoms like fever and a sore throat or fever and a cough, they're not going to end up getting tested for COVID or influenza or any other viral infectious diseases. They're probably going to stay home. If they go to a healthcare provider, the doctor or nurse practitioner will probably say, hey, look, you got a cold. We don't need to do anything about it. So it's important, if you really want to understand the possible burden of this disease, to also track people who have these symptoms. And because this data has been tracked continuously over time for a long period, it can be highly useful at tracking whether or not there is a surge in influenza-like illness, which could be due to influenza or it could be due to other respiratory viruses. Now, syndromic surveillance ideally catches all of the conditions that we're worried about, right? We're tracking cases of disease, we're tracking people with symptoms of disease, and we're tracking deaths. But it turns out that there is another form of surveillance that is critically important, and that has been hugely important in certain high profile health conditions, that we call that the astute clinician. For rare, high consequence medical conditions, the most consistently effective system, it turns out, is a phone call from a clinician to a public health agency. It requires the clinician, of course, to be familiar with their local health department. There's a very common saying in public health emergency response that you never want a public health emergency to be the first time you meet your colleagues. So one of the most important things that public health agencies can do is establish a close connection with the clinicians that work in hospitals, that work in clinics, that work in urgent care facilities, so that they know that there is somebody for them to call if they suspect somebody with a high consequence condition. Think about Ebola, or think about anthrax. Think about anything where we're really worried that this could be a devastating problem for the community. Here's an example of where we got a call about an astute clinician. In this situation, this was the first case and only case of Ebola that occurred in New York City during the West Africa Ebola outbreak. In this situation, interestingly enough, the astute clinician was the patient themselves. They sensed that they had Ebola because of the risk factors of them having treated Ebola patients, and made a point of calling their healthcare provider for the organization that they work. And then that healthcare provider called us at the New York City Health Department. Now, one of the real big challenges with public health surveillance is that it is never complete. There are always going to be problems with what we consider sensitivity and specificity. With tracking laboratory confirmed infections, these have a very high specificity. That means we have a really high degree of confidence that the person being reported has the disease. Unfortunately, there's also limited sensitivity because we know that this can be an undercount, because not everyone who gets sick seeks out healthcare and gets a laboratory test performed. When we're tracking death, this is really important because it provides data that everyone cares about. But we also know that the cause of death, as we described before, can often be inaccurate. Okay, so we know that the data that we're dealing with is always going to have some problems with it. When you think about syndromic surveillance, this is believed to have high sensitivity, but we also know that it has low specificity when you compare it with laboratory confirmed infections. So why do we track it? Well, as I mentioned before, it helps you get data quickly, particularly about conditions that you care about, like a surge in respiratory viruses. And the reason it gets so quickly is because you don't need to wait for a laboratory test to return. You can simply track all the people that came to a healthcare facility in a day, and you already have information that's potentially useful. Now, public health officials rely on a composite picture of all of these different sources of data to estimate the total burden and the trends over time. It's why public health surveillance data needs to be interpreted by epidemiologists, by people that study this all the time, because they can help understand how you pull all of these pieces of information together so that you have a real accurate estimate of the total burden of disease and how it's changing. Is it increasing? Is it decreasing? Is it staying the same? Now, how do you decide that the number of people with an infectious disease is something that you need to worry about? This gets down to a really challenging question. And it's really a question where there is no perfect answer. And the question is, how many cases is too many? So we use the term outbreak and epidemic basically interchangeably. They're basically the same term. What they mean is that you have more cases than you would expect to normally have during a specific period in a specific place. A pandemic means an outbreak or an epidemic that impacts most or all of the world and not just a few countries. This is a complex topic that involves making a judgment about how much illness and death society should accept. For example, even one case of Ebola is considered an outbreak. Some outbreaks are obvious. This is a slide showing you how the number of cases suddenly skyrockets. It suddenly shoots up. And that is a real obvious indicator that something is going wrong. You also have situations in which the number of cases is kind of slowly growing over time. And finally, you have outbreaks that are against the background of a lot of cases already. So this is a slide where you see the number of cases is jumping up and down. Suddenly it spikes up and then suddenly it comes down. And this is almost certainly an outbreak because you can see the number of cases is gradually growing, but it's occurring against a high background rate. So how do we decide if it's actually an outbreak? Well, there's something known as aberration detection algorithms that can help determine if the case numbers are higher than expected. I use, for example, in here something called SAT-SCAN. You can easily look for this on PubMed or Google it. And it's a statistical methodology to try to estimate whether the number of cases has increased in a specific area during a specific period of time. Statistical approach to counting and measuring cases. The biggest challenge, however, is knowing what is the background rate of disease. This is particularly difficult to detect outbreaks when there's a low attack rate. For example, not everyone who is exposed actually gets sick. There's the clinical syndrome may not be very distinctive. It could be something like diarrhea. Well, there are lots of people that might get diarrhea for reasons that have nothing to do with having an infection. And it could be geographically dispersed. So if you have a condition where some people get sick and other people don't when they eat a certain type of food, that some people get diarrhea, other people don't at all, or lots of people might be getting it for whole other reasons, and the cases are occurring in multiple different states, it can be very hard to even detect whether or not that is an actual outbreak. So then the next question becomes, we've decided, we've done our surveillance, we're tracking diseases, we've detected an increase in cases that we think is an outbreak. Now, how do you actually investigate the cause of an increase in people with an infectious disease? These are the steps in investigating an outbreak. Now, I'm not going to go through all of these. This is its own separate lecture, but I want you to understand all of the different steps. The first and most important step in investigating an outbreak is to actually first verify the diagnosis and then establish the existence of an outbreak. Are the people being reported actually people with a disease that we worry about, a public health condition that could be a problem for the rest of the community? And is there actually an increase in cases? Is there an outbreak? All the steps that we just did. So verify that everybody that you're looking at is actually sick with a disease you worry about, and then decide whether those total number of cases is greater than what you would expect and meets your definition of an outbreak. Now, after that becomes a whole series of different steps. We also need to define and identify cases. Just because somebody has, for example, salmonella in your community doesn't mean they're part of the outbreak. It's possible they got salmonella from a totally different food source. If you're suspecting, let's say it's a restaurant, but maybe they got salmonella from eating undercooked eggs that they prepared at home. So you need to define the sort of time, the geography, the actual pathogen that people have to decide to define what actually is a case that's going to be counted as part of this outbreak. We're going to discuss that a little bit in the next slide. You then do something called descriptive epidemiology. You just literally look at who are the people getting infected, where are they coming from, over what time period, what we call person, place, and time. You develop a hypothesis. What is it about these cases that they may have something in common? You then try to evaluate the hypothesis. You do investigations. One of the most common is something called a case control study. You interview all the people who have the disease. You interview people similar to them who don't have the disease, and you try to see, is there something about these people that indicates that they all went to this one restaurant? Your hypothesis about why they got sick. You implement control measures, and then ideally you communicate your findings so you can prevent another outbreak from the same disease or from the same risk factor. So as I mentioned in the previous slide, one of the biggest challenges here is defining what a case is. The case definition is pretty much the whole situation you're going to deal with, right? You need to decide, of all the people who are potentially sick in your community, who am I actually worried about? Who's part of this investigation and who is not? A case definition is fundamentally the criteria for deciding whether a person should be classified as having the disease of interest. This may mean clinical factors such as signs and symptoms, and may involve epidemiologic factors such as the time, place, and person, and it may include laboratory confirmation. This is critical, of course, with infectious diseases, but may be a challenge if you're dealing with a condition for which there is no laboratory diagnosis. We often divide these case definitions into several tiers or categories, such as those we consider confirmed cases, those we consider probable cases, and those that we consider suspected cases, but don't have any higher level of confirmation. Now, once you've done your surveillance, you've detected an increase in cases, and you've decided it's an outbreak and you've investigated it, how do you select policies or programs to reduce the number of people with that disease? Here we get into a framework that is really foundational to public health. And this credit goes to Dr. Tom Frieden, former director at CDC, for proposing this framework during a paper he wrote in 2010. And what you see here is a pyramid, and what is defined as or described as a hierarchy of public health interventions. Okay. At the bottom of this period, we have those interventions that have the biggest population impact. On the right-hand side, we have going up, we have those that require the maximum amount of individual effort. So if you look at the bottom, for example, we think of socioeconomic factors, things like racism, economic inequality, universal healthcare. These are factors that have a tremendous impact across the population. They benefit people regardless of whether you've gotten an intervention or whether you even know it at all. So they have a huge population impact. And most importantly, they don't require any individual effort. We don't need to get people to change what they are doing. Okay. The next step up the pyramid is what we call changing the context to make sure that individuals' default decisions are healthy. So think, for example, about taxing cigarettes. Cigarettes are more expensive, so people don't buy them as much. Inspecting foods to make them safer so that pretty much the food you're going to buy at most stores is going to be healthy, is going to be safe, free from infections. Or disinfecting the water so that when you turn on the tap, you don't need to boil that water before you drink it. Okay. So the next step is changing the context to make individuals' default decisions healthy. This benefits the population and it doesn't require much individual effort. The next hierarchy is interventions that we consider long-lasting protective interventions. And this is where vaccines come in. This is an example where people do have to make individual effort, right? Somebody has to go to a healthcare facility, or your parents have to bring you to a healthcare facility if you're a child, and you need to get a 1 or 2 or maybe 3 doses of a vaccine to be protective. The advantage, of course, is that once you've had that intervention 1 or 2 or 3 times, your body does the work for the rest of your life, right? Your immune system is now boosted and does all the work to protect you anytime you're exposed to those infections. So that's why vaccines are so important to public health. And when we look at the history of the greatest impact we've had in the 20th century on reducing illness and disease, so much of it depends on improving overall socioeconomic status, removing barriers to people's civil rights or access to healthcare facilities, and then making our food safer, our water safer, our air safer, and then incorporating vaccines. Those are because socioeconomic factors, changing default decisions, And long-lasting protective interventions can have a huge and profound impact on the health of a population. Next step is what we call clinical interventions. And unfortunately, this is what a lot of people think about when they think about health. They think about what happens when I go to doctors and what does the doctor do to help me get healthier. While these can be very important, they require a tremendous amount of individual effort, right? You have to go to a healthcare facility. You have to get tested. You might have to take medications for a long period of time. You might have to get surgery or other things. This requires a lot. And so we know that a lot of people drop out of the healthcare system because the healthcare system isn't welcoming, it's too expensive, or it requires too much effort and work on their part. So that's why clinical interventions are important. But when you think about their overall impact across a population, it's going to be less than the other things I mentioned. And the last is what we call, counseling and education. For example, think about telling people to avoid high risk settings or encouraging them to wear masks. These are all things that we need to do, right? They're considered foundational because they're very simple to do. All you have to do is send the message or make an advertisement. But we also have to be realistic. It's very rare that broad scale educational campaigns on their own are going to have an impact. Think, for example, about cigarettes. We all know that cigarettes are toxic to your health. They can cause a huge number of cancers, lung disease pretty much in every organ in your body. But widespread education doesn't really make the biggest impact on reducing tobacco smoking. The biggest impacts come from taxation, making cigarettes harder to get and more expensive. Doesn't mean education isn't important, but it just means we always have to be realistic about where we're going to get the biggest bang for our bucks. So let's think about this. For example, when we think about everything that we've talked about in this lecture, we get back to a question that I raised earlier, which is how many cases is too many? So let's go back to COVID again, since this is an example that everybody is familiar. How many COVID-19 cases is too many? The consensus after the peak of the pandemic has largely been across society that we must learn to live with COVID-19, that there's no way it can be eliminated from our society. So what this means is that we're willing to accept a certain number of people getting sick, and I denoted that with the letter X. So we're willing to accept a certain number of people getting sick, a certain number of people going to the hospital, and a certain number of people dying every day from COVID-19. Because we have decided as a society that the cost and effort to reduce those numbers to zero is too much. Now, fundamentally, that is a values decision. And I'm not saying that anybody's values are wrong about this, but we always have to recognize that this is fundamentally a decision that we are making. We have the ability in public health to decide to a certain extent how many people can live and how many people can die from certain conditions, right? Some things can never be prevented, but there are a lot of things that could be. But we're always making a value decision at some level about how much cost and effort is needed to reduce the numbers to zero. So let's think about some obvious examples. We could actually have zero traffic deaths if we banned all cars, but that would mean that people couldn't use their cars for the things that they need them for all the time. We could have zero sexually transmitted infections in teenagers if we locked them up in their homes and never let them leave until they were an adult. But that's not acceptable. That's not practical. So how do we think about it? How do we think about this in a rational and clear way about how many cases of COVID or any other health condition is too many? Fundamentally, it comes down to a few considerations, okay? And the key to remember here is there are no absolute answers to this. If you come to this perspective from that of a libertarian, somebody who believes in limited government, then you're going to have a very completely different perspective than somebody who comes to this from a communitarian or maybe a socialist or progressive perspective, where you believe that we have an obligation, we as individuals and as a community, to protect other people, and we need government to actually do that work. So this isn't an argument about whose values are right. It's an argument about making explicit what our values and beliefs are. But it also needs to start with some scientific evidence. Okay, so what are the factors? The first is, does the intervention work? That means we have evidence from studies to show, for example, that vaccines work. It's feasible. We know we have the staff to get the vaccines to people. It's acceptable. We know that people are willing to get vaccinated. Next, we believe that the totality of benefits are greater than the harms. We know that there's a lot of benefit from people getting certain vaccines and very little harm. We can afford it. We have the money to actually buy vaccines. Our government has the money available to us to do it. And finally, it aligns with our values. We value people, protecting people from a disease like COVID or other vaccine preventable diseases that has sickened and killed a lot of people. So again, the factors you need to make if you're a decision maker is, do we believe it works? Is it feasible in my population? Is it acceptable in my population? Do we believe that the benefits overall are going to be greater than the harms when we do this intervention? Is it affordable in our population? And does it align with our values? If you're also in a position of public health authority, you also have to make sure it's legal to do as well, because we know that in certain places, in certain states, there's going to be different laws in place about what government has the right to do and what it does not. So putting this all together, we have what we call the public health approach, which is we first do surveillance to decide, is there a problem? Next, we decide if there's an outbreak, if we detect that there's a problem, what are the causes of that problem? And finally, we develop our interventions and we say, can I actually reduce this problem? And then we go back to doing public health surveillance to say, hey, is our intervention actually reducing the number of people with a certain disease? So there you have it. That is a whirlwind overview of how we detect and respond to infectious diseases. I hope you found this useful. And my name again is Dr. Jay Varma. I'm a physician, an epidemiologist, and public health leader. Be well.